Again, thank you very much for inviting me to this prestigious meeting. So these are some basic facts that we're all very familiar with. If we have critical limb ischemia, if we don't address it, the risk of amputation is very high. We'd like to revascularize with best vessel approach to heal the wounds. However, we know that even with a patent bypass and inline flow, the reported risk of limb amputation can be up to 18%. So I think we're very familiar with this angiosome-based revascularization concept, angiosome being a three-dimensional tissue block between skin and the bone. It's approximately 40 angiosomes in the body with 6 in the foot. And it's been hypothesized that direct angiosome revascularization may have higher rate of wound healing. So how is that? It was looked at various configurations of patients, percutaneous, hybrid, as well as open. And the most recent meta-analysis by Dr. Sesja actually show that these patients groups are poorly matched. They're not randomized. There's a wide variety of techniques. And although there are trends that show that direct revascularization versus indirect revascularization may lead to increased limb salvage and wound healing, there's really no clear guidance as far as this is concerned. So how do we do it at Westchester Medical Center, which is my center in New York, when we have patients with tissue loss? So I don't think we vary from what everybody else does, which basically we do full vascular assessment, history exam, non-invasive flow studies, and early angiogram. We still resort to reverse great esophagus vein bypass to the best artery. However, it is not our gold standard. What we find the most difficult in these patients are situations when foot vessels are diseased, and for these cases, we routinely attempt aggressive pedal percutaneous revascularization to guide and improve our wound healing. So I just want to talk about some of our good, bad, and ugly cases of such revascularization. So this is a typical lesion, although the patient may not be as typical. It's a 40-something-old-year male with gangrene of the distal toe tip. He has diabetes for most of his life, kidney transplant, his creatinine is high, he has palpable femoral and popliteal pulses with absent pedal pulses. So this is his initial foot angiogram, and one can appreciate very minimal flow in the dorsal pedal artery. So upon successful traversing with a wire, we perform plain old balloon angioplasty. The results, we follow with the pedal loop angioplasty. The results in a much improved flow of blood into the digits, and that is really impressive. And in this good case, we actually have gradual healing with complete resolution of his toe wound. So in order to be successful with these interventions, we think that visualization using high field DSA is a must, and we use for it predominantly hybrid OR setting. However, we also utilize cardiac cath lab. What we do for our access is predominantly antegrade access to avoid any vectoring during going up and over. As far as equipment that we use, we start with microchannel wires, hydrophilic, followed by increasing gram, either CTO wires or very aggressive tapered wires. These are wires that are available in the United States, but any really wire that has similar characteristics can be used for it. And we try to cross intraluminally rather than subintimately. So this is a patient from the previous slide on the right side. Again, typical situation when we are successful in revascularizing, again, pedal loop. In him, the arch is not complete, so we go from the posterior tibial artery that we cross. We perform angioplasty of the posterior tibial artery to meet arch vessels. And what's going on? He's not improving at 6 weeks. His toe is looking worse. We bring him back. We perform digital branch intervention. There's a stenosis that's not very well visualized, but it is at the bottom of the screen. We perform very low profile balloon angioplasty of the artery at the level of metatarsal bone. This is the completion angiogram. It is improved. And this is followed by slow but complete wound healing. So what are the bad situations of lesion crossing? So it's another patient with severely calcified lesion at the dorsal pedal artery. We can appreciate either chronic total occlusion or minimal microchannel flow. This is an attempted crossing with a balloon, low-profile balloon, and unfortunately what we have is a massive extravasation with a vessel injury. So it's a bad situation. We try to stop the bleeding. We also don't want to lose the vessel. So during deep dorsal pedal artery perforation, actually one has to notice that the wire is already out. We back out, we get back in, we perform balloon tamponade, and then following this, the patient has preserved flow. However, we did not achieve anything. In this patient's case, we were lucky enough that after partial foot amputation and advanced wound healing, we were able to heal this wound. So what do we do to aid calcified lesion crossing? We predominantly use low-profile coronary hydrophilic semi-compliant balloons, 1.2.5 and 1.2 millimeters. We also use low-profile hydrophilic coated taper tip catheters, and again, any company can be used for that. We frequently use Quick Cross as our to-go catheter. What we find most useful for these lesions is actually a laser atherectomy, especially applying the smallest diameter of the vessel, the fiber of 0.9 millimeters. So what are some of the worst cases? This is again pretty routine dorsal pedal distal anterior tibial artery revascularization. The balloon is in place. We have a completion angiogram, and what do we see? So I can tell you that this posterior tibial artery was not visualized on the opening angiogram. Now, this is the only vessel, reminding you that we're targeting the dorsal pedal artery. So this is consistent with dorsal pedal artery thrombosis, probably also associated by partial vessel dissection. In this case, we wanted to address it with mechanical thrombectomy. We use for that an angiojet device, the catheter of the angiojet that's in the distal part of the foot. However, any type of thrombectomy catheter can be used. For that, you can use Indigo system or any expert catheter and whatnot. So this was successful, and after several passes and vasodilatation, we were able to restore patency of this vessel, which is the dominant vessel of the foot, and the lesion is in the toe. So subsequently, this patient underwent partial toe amputation and was able to heal his foot. So transbypass interventions is just one of the applications of this technique. This is a patient who had a non-healing forefoot of the wound lesion. He had a previous FEMPA bypass. We felt that maybe indirect revascularization in his case would be successful. However, with this appearance of the foot flow, it was clear to us after a while that that was not going to be the case. So again, this is a transbypass angioplasty of the dorsal pedal artery, which upon opening and partial foot amputation and advanced foot healing, the patient was able to preserve foot function and ability to ambulate on this limb. So what about failure? Well, this is another patient, typical patient with only one single vessel runoff through the dorsal pedal artery that is heavily calcified. And again, there's a big chunk of calcium sitting right there in the middle of the picture. We tried to cross it. Again, we have a massive extravasation. This lesion is too calcified. We're unable to pass anything over our wire. It's a pretty dramatic situation because this patient, being young, 60s, very active, he has a lesion in the toe region, and really he does not have a whole lot of flow to the foot. Interestingly, upon completion angiogram, again, we're able to save this vessel from complete occlusion. We see there is a wisp of posterior tibial artery. So what we do is, come on. Well, it's not playing, but basically we did a bypass to the posterior tibial artery, and the slide was supposed to show there is very minimal flow to the forefoot. So the bypass is in place. It's an indirect revascularization. However, the patient is failing wound healing. Toes and a distal foot is still ischemic, so it's still work in progress. He underwent partial foot amputation and awaiting his healing. So in summary, for improved lesion crossing for pedal interventions, we feel that prograde access is a must. We fail most frequently when no instrument can't advance despite the wire across the lesion. There is no, at least in our opinion, critical role for crossing with devices and stents in this location. We find that particularly difficult lesions are at the inferior extensor retinaculum. We think that older patients have heavier calcifications and longer multi-level stenosis. and we have low threshold for reintervention if wound healing is poor. So we find these interventions extremely valuable. We use PTA first with direct revascularization over indirect. At present, literature does not clearly guide to what type of revascularization is best, and I can't stress enough that dedicated wound care with close patient follow-up until wound is healed is extremely important in care of these patients. Thank you very much for your attention.